So, like I said, I'm Dr. Eric Geisler. I'm the medical director here. This is called the Disease of Addiction Lecture. Here at Serenity Lane, we consider alcoholism and addiction to be a chronic, relapsing neurological disease that's potentially fatal. And if we're going to talk about addiction as a disease, then we like to talk about what does it mean by the definition of disease. So a disease is a problem where, let me back up. So I find that patients and families are very receptive to this idea that it's a disease. Law enforcement is on board with this. That's why we have the drug courts. I find my most difficult audience is medical people, especially physicians, for a whole lot of different reasons. But we view it as a disease of the brain that's very similar to Parkinson's disease or Alzheimer's disease, where it's progressive and can be fatal. So if we're going to talk about addiction and alcoholism as a disease, we need to understand what the word disease means. And essentially, disease is where an organ or an organism has a dysfunction, something's not working right, and then that leads to symptoms, which is what people complain about, and then eventually develops signs, which is something that can be viewed by an outside person, whether it's a doctor or a nurse or a family member. And then we might do a test, we make a diagnosis, and then we come up with a treatment, and the treatment is to try to improve the dysfunction and alleviate the symptoms. So the easiest example of this to understand is a broken leg. What's the organ involved? Leg bone, okay. Shout it out. I like interruptions and questions. What kind of symptoms are you going to have if you break your leg? Pain, not being able to walk. What kind of signs are there going to be? The bone's sticking out, the leg's crooked. What test am I going to order? X-ray. What's the treatment going to be? Yeah, cast, surgery, or both. Okay. So the medical community likes to compare alcoholism and addiction to diabetes. And what's the organ involved with diabetes? The pancreas. And what's the dysfunction? Doesn't make insulin, or the insulin it makes doesn't work properly. And what kind of symptoms do people with diabetes get? Thirsty all the time, blurry vision, peeing all the time, maybe some weight loss. And then what kind of signs do you see from the outside? That's a little tougher question. Maybe weight loss. They might have sores on their feet. What test am I going to do? Yeah, we're going to poke your finger and check your blood sugar. If you're diabetic, you might know what a hemoglobin A1C test is. And then what treatment do we give for diabetes? Insulin. You might get a daily injection of medicine, insulin, or you might get pills, or we might ask you to make lifestyle choices that are different. We may ask you to change your diet. We may ask you to exercise. And if you do everything right and the diabetes comes under control, we may take medications away and you just live with some lifestyle changes. However, sometimes you do everything right with diabetes and you still need to stay on the medication for the rest of your life, the insulin or the pills. Some people who are skinny and eat very well can develop diabetes, and sometimes people who are heavy and eat like hell don't get diabetes. Well, what's the difference? Well, there's a genetic difference. There's a genetic predisposition to develop diabetes. So if you like to put sugar on your Frosted Flakes, that doesn't necessarily mean you're going to develop diabetes later on in life unless you have the genetic tendency. So keep that in mind as we talk about addiction. So what's the organ involved in alcoholism and addiction? Oh, the brain, right? And here's a little tougher question. What's the dysfunction? What's the dysfunction? So all the geniuses that work in addiction medicine like to say the dysfunction is there's something abnormal about the reward and behavior circuitry of the brain. There's just something genetically different about people that develop this problem in the way they respond to stimulus and then what their behavior is repeatedly. And what kind of symptoms do people with alcoholism and addiction complain about? What do they come to Serenity Lane complaining of? What was that one? Shakes. Okay, that's a symptom of withdrawal. What do you guys tell me when I ask you? Memory loss. How about I just can't stop drinking? Right? How about I can't stop using methamphetamine? How about if I don't take my Percocet, I get really sick? Or how about I've been trying to kick heroin and I just can't stick to it? Okay? Or how about I just got my 3rd DUI? Or I'm on my 4th divorce? Or Children's Services has custody of my children. So these are things that people come to Serenity Lane complaining about. And then what kind of signs do we see? I kind of hinted at it. Maybe blue and red lights in the rearview mirror. Okay. Maybe handcuffs, right? Maybe you're back in court for a custody battle. Maybe you're getting divorced again. So these are some common signs we can see. Maybe you have other legal problems: drunk and disorderly, minor in possession, possession with intent to distribute. These are all signs of addiction. Can I do a test? Can I do a blood test as you're alcoholic? Not really. Can I do a blood test that says you're a cocaine addict? No. But when you checked in here to residential, we put a number 2 pencil in your hand and gave you a test, right? 342 questions. Okay. 344? Yeah. So, part of the test is, did you finish it? Right? All right, that's called a personality inventory, and that can give us some hints. But how do we make the diagnosis of alcoholism or addiction? Well, we use something called the DSM-5 criteria, which is a book written by a bunch of nerdy psychiatrists, and they have come up with 11 criteria for making the diagnosis. And those criteria break down into what I call the 4 C's, and then there's some other things. So the 4 C's, the first one is lack of control. Once I start drinking, who knows how much I'll drink. I have 1 beer, I stop by the bar on my way home, and I don't know what time I'll get home. Loss of control. Continued use despite consequences. My favorite story, young man was coming up from Southern California to come to treatment. He'd already had 1 DUI in his past. He got a 2nd DUI somewhere around Ashland, kept driving north, kept drinking, and was pulled over outside our gate, ran through the gate, and was tackled in the grass in front of my office and was handcuffed and was given his 3rd DUI. And when they realized where he was, they let him come into treatment. Okay? So that's continued use despite consequences. Okay? That's also an example of good addictive thinking. Yeah. And then compulsion, meaning I have no ability to not use. I don't know alcoholics that keep a 6-pack in the refrigerator for a week because they drink it. Okay? Or if you're an opiate addict and you find 2 Percocet under the seat of your car, boop, pop them in your mouth and swallow them before you think about it. No ability to not use. Compulsion. And then finally, craving. There's no medical definition of this word, but most people in this room will understand what I'm talking about. Where if I have 1 beer, then I get really thirsty and I want another and another and another. It triggers a craving. Or if I have a little bit of methamphetamine, well, I'm going on a rampage, I want more and more and more. Or it's if I'm not using, I can't quit thinking about using. I'm planning the tailgate party on Saturday. When am I going to score my next dope? How much can I get? Where am I going to get the money? A continuous obsession of the mind, a craving about your drug of choice. Another factor is tolerance. Does it take more and more of the same to get the same effect? College freshmen might drink 2 beers, they're a cheap date. By the time they're a senior, they can drink a 6-pack and they hardly have a buzz. They have an increasing tolerance. Do I suffer withdrawal symptoms? I've been prescribed Percocet for my back pain for months. If I don't take them, I start getting the sweats and diarrhea, feeling sick. I'm having physical withdrawal without my drug of choice. And then finally, do I continue in risky behavior while I'm using? Probably the most obvious is drinking and driving, sharing needles, drinking and climbing up on the roof to fix the antenna for the television. Risky behavior. Most alcoholics don't die of alcoholic liver disease, they die of stupid. They're drunk and they do something reckless. So risky behavior. So we make a list of these criteria, and if you're sitting in this room, you met the definition of severe, you probably had 6 or more of these criteria. And if you have none or 1, we'd say there's no diagnosis. If you have 2 or 3 of these criteria, we'd say you have a mild problem. If you have 4 or 5 of these criteria, we'd say it's moderate. If you have 6 or more, we say you have severe alcohol use disorder or severe substance use disorder. And November 2016, the federal government published a 450-page report, the Surgeon General, that said alcohol and substance use disorders were a major public health problem. Like, duh, right? So the smartest thing they said, since smoking is bad for you. But what they did do was, for the first time, they defined the word alcoholic in a way that the medical community and the legal community could agree. And what they said was, if you have an alcohol use disorder that is severe and chronic, meaning more than 6 months, then you're an alcoholic. And if you have a substance use disorder, cocaine use disorder, severe, that's been going on for more than 6 months, then we say you're an addict. So if you've got your 3rd DUI, you can't not drink. You drink until you have severe problems and you have withdrawal, and it's been going on for 6 months or more. Does that sound like an alcoholic? Sure it does. Sure it does. So that's how we make the diagnosis. Okay. So if we have a disease, then it should have similarities to other diseases, in that maybe there's a genetic component, maybe there's something in the environment that triggers it, and then there should be some sort of biological model that helps explain what's going on. So genetics, what do we know here? Well, for alcohol, ETOH is shorthand for alcohol. For alcohol, we know in the background population, how many people out of 10 have a problem with alcohol by age 25? What do you think? Yeah, it's about 1 in what? 1 in 8. So 1 in 8 people will have a problem with alcohol by age 25. Does that mean they meet that strict definition of alcoholic I just went over? No, but maybe they got their first DUI, or maybe they went to the doctor and they were told their liver enzymes were elevated, and the doctor told them to cut back on their drinking. So that comes to about 12.5%. If you have one alcoholic first-degree relative, meaning mom or dad, what do you think? It's higher or lower? Higher, yeah. By how much? Well, about twice as much. Equals about 25%. And if you have 2 first-degree relatives, dad and brother are alcoholic, or mom and dad are both alcoholic, what do you think? Higher or lower? Higher again, by as much as 4 times, which is about 50%. And if you have an identical twin, same genetics, one twin grows up in an alcoholic home, becomes an alcoholic, what are the chances of the identical twin growing up in a different home having alcohol problems? What do you think? about 50%. So we like to say that alcohol has at least a 50% predisposition to developing alcoholism. So sort of like our diabetic patients. Just because you ate a bunch of sugar, that's not what made you diabetic. What made you diabetic was the genetic predisposition to develop diabetes. The same with alcohol. Just because you drink alcohol doesn't mean you're going to become an alcoholic. There must be a genetic predisposition for this to occur. Some people are more susceptible than other people. And we're like, well, geez, if it's genetic, can we look at your genetics on 23andMe and figure it out? And the answer is they can look at certain genes and estimate what your risk is, but we can't say, oh yeah, you're going to become an alcoholic, or oh, you're at risk. So we don't have a blood test yet to tell us you're likely to be an alcoholic, but it's a good research tool. You can get online and order some of these genetic testing, and they'll give you an estimate of your risk, but it's not ready for clinical practice yet. Okay, so what else do we know? Well, we know something about opiate patients. Do you think that in the background population it's higher or lower than alcohol problems by age 25? Higher, yeah. You'd think it's higher based on all the noise in the news, but it's actually lower. It's about 1 in 25 people will have a problem with opiates by age 25, which is about 4%. Okay? So if you have a first-degree relative that's a heroin addict, dad's a heroin addict, what are your chances of having a problem with opiates by age 25? Or actually having a problem with any substance by age 25? What do you think? Yeah, it's pretty high. It's about 40%. Okay? And if you have 2 first-degree relatives, what do you think? Mom and dad are both heroin addicts. What are your chances of having a problem with opiates or other substances by age 25? It's about 80%. Yeah, so what I tell folks is if you come from a family where both parents are heroin addicts, you need to be very, very careful about using opiates, even if they're prescribed legitimately for surgery, that you have a very high genetic predisposition to developing a problem with opiates. So we do not know much about other substances, methamphetamine or marijuana, but we have very good studies about the genetics of alcohol and opiates. Okay, so you have this genetic predisposition. What in your environment is likely to trigger you developing a problem? What do you think? Is it available? Yeah. So I always ask everybody, how old were you when you first used? Age of first use. And then something called an ACE score. And if your ACE score is greater than 4, you can double some of those numbers I just put up there. Okay, well, what's an ACE score? Well, that stands for Adverse Childhood Experience. If you were the victim of physical or sexual abuse, you get 2 points for each of those. If you grew up poor, meaning you missed meals, you moved around a lot because you didn't have good housing or you didn't have adequate clothing, then you get a point for that. If you grew up in a single-parent household or your parents were divorced before age 12, you get a point for that. If you were a witness to violence, mom and dad fighting, you get a point for that. So, and a few other factors. So, but if your ACE score is greater than 4, you can double your risk of developing problems. Okay? And then age of first use, what do we know there? Well, lots of studies on alcohol. Turns out if you're a regular drinker at less than age 18, what are your chances of having a problem with alcohol by age 25? What do you think? About 40%. Yeah, by age 25. Okay? And then the other one we know something about, marijuana. Okay? Marijuana. Very good study published in 2012. Gets lots of references in different medical journals. I want you to pay attention to this date. We'll come back to that. It's very important. So This study showed that if you smoked marijuana on a regular basis before age 16, what are your chances of developing a substance use problem by age 25? What do you think? It's about 50%. Okay? The second part of this study that was very interesting, gets a lot of attention, was they looked at IQ. They followed these people from age 15 to age 30. It was a very long study. And they found out that there was a loss of IQ of 8 to 13 points that was permanent if you were a daily marijuana smoker at age 16 or younger. Okay? Now, what does that mean? Well, if you graduated high school with B's and C's, you have an IQ of 100, you're an average person. Okay? If you're a genius and you have an IQ of 125 and you knock 13 points off of it, 112, you're going to be fine. Okay? But if you barely graduated high school, you had an IQ in the mid-90s, and we knocked 13 points off, you're going to be in the low 80s, formerly known as mentally retarded. Okay? So that impairment is permanent. So they don't call it dope for nothing. Okay? Well, why is that date important? Well, if they published it in 2012, it means the study was done somewhere in 2011. What kind of dope were they smoking in 2010, 2011? Crap, skunk weed, right? Okay, not the sophisticated flower we have in Oregon today, right? So, and they didn't have concentrated vape oil like we have today. So I really worry about the younger people today. They're being exposed to these high quality, high concentrated marijuana products. Okay. So now we talk about a genetic model. So in the 1970s, we had no idea what was going on in the brain with people that were alcoholic or opiate addicted. So they decided to try to figure this out, and they started with monkeys, because apparently monkeys are similar to humans. Okay? And they literally drilled holes in the monkeys' heads, put little plastic straws in, hooked the straw up to a machine where the monkey could get a choice to push a bar and get a dose of cocaine, or they would try to distract the monkey with food or a toy or another sexy monkey to play with. Okay? So they started out in the frontal lobe. This is the part of the brain that has to do with memory and personality, and they thought for sure this was going to be the problem area. So they hooked the monkeys up to this machine, and sure enough, they pushed the bar. They liked getting cocaine, but they were distractible. So the researchers were disappointed. So then they decided to come down here on the brain stem, called the medulla oblongata. It's my favorite word. It's got a nice rhythm to it. So, and this is this part of the brain controls heart rate, blood pressure, breathing. And sure enough, the monkeys pushed the bar. They got their dose of cocaine, and what they got was some really excited monkeys with high heart rates and high blood pressure, but they were distractible. So then they decided to try the cerebellum back here, the back of the brain. This has to do with balance, coordination, and speech. No surprise, that wasn't the magic bullet. And then they tried it here in the midbrain. The midbrain is a very old part of the brain, evolutionary-wise. This part of the brain has to do with eating, reproduction, sleeping, and in human beings, emotions. And I like to call this the fudget part of our brain. And this is the part of our brain that when someone cuts you off in traffic, you communicate before you think that maybe they're a concealed carry permit holder. Okay? This is the part of our brain where you're on a diet and you see a great piece of chocolate cake and fudge it, my diet's over. Okay? Or you pound your thumb with a hammer, it hurts, and you throw the hammer before you think there's a plate glass window behind me. Okay? Or it's the part of our brain where you're in a committed relationship and you see another sexy monkey to play with and the relationship ends. Okay? All right. So it turns out when you give cocaine to the midbrain, it releases a very strong neurotransmitter called what? Dopamine. Right? And how does dopamine make us feel? It makes us feel great. That's why we like cocaine. Right? Not good, it makes you feel great. Okay? So it turns out you get this giant surge of dopamine to the frontal lobe, and you form a very strong memory of how great that was. Okay? And you repeat that behavior because you like it. And then over a period of time, the brain starts to adjust. And when you run out of cocaine, you feel lousy. Okay? And it turns out that if you want human beings, or any mammal for that matter, to repeat a behavior, it's much stronger to make a negative go away than it is to continue to repeat the positive. And I know this is true in my patients because they tell me, when I wake up in the morning, I have to find $100 to score some dope so I don't feel sick. I had a gentleman, he's a 30-year IV heroin addict, very successful guy, made a lot of money, and he said, getting high annoys me, but I have to get up every day and find some dope so I don't get sick. Okay? Making that negative reinforcement go away. Or methamphetamine patients tell me, you know, I can go a couple of weeks without using, but I get so tired of feeling flat and feeling nothing that I use just a little bit so I can feel normal. Okay? And then they overshoot the mark and they're back into this cycle of addiction, we call this abnormal behavior reward cycle that seems to be the problem in alcoholics and addicts. Okay, so that's cocaine. That's a pretty easy one to understand. We mentioned meth. What's the neurotransmitter involved in meth? Dopamine. That's why we do meth. Makes us feel good. And somebody said the other one, serotonin. What happens if you stimulate serotonin too much? You start getting a little paranoid. Maybe you start hallucinating. My favorite scene in Breaking Bad, Jesse Pinkman's enjoying some meth in his home, and the LDS missionaries come up to his front door on their bicycles and white shirts, and he sees them as these monsters on motorcycles. Right? He's hallucinating because he's stimulating serotonin a little bit too much. Okay? Well, if you stimulate serotonin over and over again, your brain stops making so much serotonin, and you start to feel very flat. Okay? And some patients naturally don't make enough serotonin, and their diagnosis is depression, right? So we put them on medications called serotonin reuptake inhibitors, otherwise known as antidepressants. And for patients who take a lot of methamphetamine for a long period of time, and we don't have a good definition of that as physicians, we sometimes put people on these serotonin reuptake inhibitors to counteract this negative. And we prefer one called Wellbutrin for some technical reasons. So if this is something you want to talk about with me because you have methamphetamine in your history, then you can make an appointment with me at RHS and I'll sit down and we can talk about it. All of the hallucinogens, whether it's PCP, LSD, ecstasy, psilocybin, they all work the same way. They all stimulate dopamine and serotonin. The difference is in to what ratio and how long they stay in your body. So if you read about somebody on the internet stripping off their clothes, running down the street, and trying to eat the neighbor's dog, they're probably on flakka, which is a very strong stimulant and a very powerful hallucinogen. So that's how they all work, pretty much the same way. Okay, so that's hallucinogens, meth, and cocaine. The other big one is alcohol. What's the neurotransmitter involved in alcohol? Oh, okay, so GABA. GABA is what I call the chill chemical. And it's made by the entire brain, And when you drink alcohol, alcohol is a downer, so it suppresses the suppressor neurotransmitter. And so you get a newbie, it's New Year's Eve, they have their first drink or two, they're suppressing their suppressor, and what are they like? Well, they're talkative, they're having a good time, they're dancing with the other sexy monkeys, right? Putting the lampshade on their head. So they're suppressing their suppressor. But alcohol itself is a downer, it's a suppressor, and as your blood alcohol level gets higher, it starts to impair other parts of the brain. The emotional center of the brain starts to impair the cerebellum. And the state of Oregon says you're not allowed to drive a vehicle if your cerebellum is impaired at what level of alcohol? 0.08. Never had an audience get it wrong. Okay? And if you continue to drink and you get your alcohol level high enough, you can suppress the medulla oblongata and you can overdose and die on alcohol. What level do you have to get that? 0.40, a little bit higher. Turns out it's 0.50. 50% of human beings who do not have a high tolerance will die with a blood alcohol level of 0.50 or higher. Every spring you'll read about some fraternity where the pledges funneled vodka and then got thrown in the trunk and they die. Okay, blood alcohol level of 0.50. What's the record on admission here at Serenity Lane? Walking and talking. 469. Little old lady that wore oxygen. So they found her face down in her home. Surprised she's alive, but she did very well with us. On average, what do you think the average is? Walking into my unit, talking to me. 0.25, roughly, okay? So if you're 0.25 and you're walking and talking and, oh yeah, I'm a little buzzed, doc, you have a very high what? Tolerance, right? This is a fifth a day kind of drinker, maybe a liter of wine, a couple beers on top of that, kind of typical story, okay? So what do? You come in the hospital unit and I have to detox you. You have no GABA. Your electrical system is beginning to ratchet up because the downer has been taken away. The alcohol level is dropping. The medulla oblongata starts getting super active. What do you look like? Blood pressure's up. You're red in the face. Then the cerebellum gets involved. Get those shakes somebody was talking about, right? Are you emotionally stable? Of course not. You're crying or you're super irritable. You're not sleeping well. Your appetite's all over the place. All right? And if your frontal lobe starts to get too active, you start to hallucinate. We call that the delirium tremens. And if the whole system starts to go haywire, uncontrolled electrical activity in the whole brain, we call that a what? Seizure. Yeah, you're on the ground, flopping around, biting your tongue, pooping your pants. That's no fun. Okay? That's life-threatening. Okay? So my number one job here at Serenity Lane is to prevent withdrawal seizures because they're life-threatening. So I give you what kind of medicine? Benzos, right. Which one do we like here? We like Librium because it's very old. It's been around a long time, very predictable. And it's a benzo. And how do benzos work? Well, they mimic GABA. Huh. Okay, well, that's nice. Well, what if you already like benzos? What if you have a problem with benzos? Taking 12 milligrams of Xanax a day on top of your fifth of alcohol. What? People do that? Sure they do. Things I learned when I took this job. So then if you're taking benzos already and you have a super high tolerance to alcohol and you're on benzos, then we add a medicine, somebody said it, called gabapentin. Gabapentin is a seizure medication. And the word GABA is in there, not coincidentally, because it forces the brain to make more GABA. Okay? Takes some time for it to work, a day or two. So we have to load you with huge doses of Librium, start you on gabapentin, and then when we take the Librium away, the gabapentin starts to work, and we can detox you off alcohol and benzos or just benzos. So that's how that works. Okay. And then finally, the last one I like to talk about is Marijuana. Okay. What's the active ingredient in marijuana? THC, tetrahydrocannabinol number 9. THC. What's the other active ingredient? CBD. Why do we like CBD? Oh, you know what? I jumped ahead. I'm going to back up one. Skipped over the opiates. There we go. I knew I was forgetting something. Okay, opiates. Why did we invent opiates in the first place? Pain, right? So I broke my leg, the bone's sticking out, it hurts a lot. So where are the opiate receptors? Well, opiate receptors are down here on the spinal cord. And they block that pain signal coming up the spinal cord about your broken leg. There's also some here around the midbrain, so you're not screaming your head off, emotional about your leg being broken. You sort of go into this sort of shocky state. There's a few up here in the frontal lobe, not too much. Okay? So if you're really high on opiates, are you emotionally available? No, you're. All right? Okay? So if we strip the opiates off and you start to go into withdrawal, what does that look like? Well, first of all, the medulla oblongata gets involved pretty early. You start sniffling, right? And your pupils get real big. And then all the hair on your arm stands up on end. There's opiate receptors in the gut, so you start to feel nauseated. Maybe you get some diarrhea and some vomiting. Okay? And are you emotionally doing well? No. All over the place. Irritable, can't sleep, appetites everywhere. So then what do we do? Well, an opiate is an opiate is an opiate. Oop, that's not the greatest picture. And all the opiates are the same, whether it's heroin, morphine, oxycodone, hydrocodone, Dilaudid, or fentanyl. They all fit into the opiate receptor the same way. The only difference is how powerful they are per milligram and how long they stay in your body. There's two parts to the opiate receptor. The kappa part, which has to do with pain, and the mu part, which has to do with euphoria, but unfortunately also has to do with overdose. Suppresses your breathing. Okay, so an opiate is an opiate is an opiate. And when we start to strip the opiates off the receptors, like I said, the first thing that gets involved is the medulla oblongata and then the midbrain. Okay, so how do we deal with it here in detox? Well, we start to give you a very special opiate called buprenorphine, and buprenorphine does not stimulate the mu receptor very much. I used to say it all, but I had patients in the back of the room waving their hands saying, oh, if I take enough bupe, I can get high on it. Okay? But it doesn't stimulate the mu receptor very much, and we like that as physicians because it makes it virtually impossible to overdose on buprenorphine by itself. Now, if you mix it with alcohol and benzos, you can do that, but you have to be very intentional, and it takes a lot of both to make that happen. So once you start into withdrawal, then we like to give you the buprenorphine to relieve those symptoms of withdrawal, and then we withdraw you from the buprenorphine, hopefully rather quickly. Buprenorphine is a very strong attacher to the receptor, much stronger than the other opiates. So if we give it to you too soon, it will throw you into withdrawal or precipitated withdrawal, and you won't like me. So I wait until you're good and into withdrawal before we give you this medication to relieve it. And then we taper it off. What was that? Yeah, the aches and the cramps and the wanting to just get out of yourself. Yeah, it's miserable, right? Okay, so that's the opiates, and we'll come back to that as well. Okay. And then finally, we'll go back to the marijuana. Okay, so THC and CBD. Okay, why do we like CBD? Pain, right? So where are the pain receptors going to be for CBD? Well, down here on the spinal cord, right? So very little up on the midbrain. Okay? So you can take a lot of CBD and you don't get high, right? You're not impaired. Does it work for pain? Well, research shows that patients that are chronic pain patients on opiates that use CBD use less opiates. I can't argue with that. Okay? Patients that have chronic pain that are not on opiates that use CBD report lower pain scores. Can't argue with that. Okay? But here's the problem. You cannot separate THC and CBD completely. And usually there's somebody in the room waving their hands, oh yeah, I can get this product, and blah, blah, blah. It's impossible chemically to separate them. They separate them at the plant level. And for the life of me, I can't keep straight indica or sativa subspecies of marijuana, that which one has the higher one, but pun intended. So you cannot separate THC from CBD. So if you're going to use a CBD product for chronic pain, be warned that you are very likely to trigger a marijuana screening at your employer if they require a urine drug screen. Okay? I don't care if it's topical or oral or any other method. If you're taking CBD, there is some THC in there, and you just need to be warned it can trigger that. Okay? So if you're going to drop that cup off at your employer, turns out that you have to have at least 50 micrograms per milliliter of THC metabolites in your urine to trigger that cup. Okay, you guys don't care about the units, but pay attention to the numbers. Okay, the half-life of THC in the average person is 5 days. What that means is it takes 5 days for half of the THC to get on your system on average. Okay, now if you're lean and mean, it'll be faster. The fastest I've calculated here in patients is 48 hours, okay, half-life. If you're big and soft and you have a lot of adipose tissue, THC is a fat-soluble molecule. It soaks into your fat tissue, and when you stop using, it starts to come out of the fat, and it takes longer to clear it from your bloodstream. All right? If you have liver disease, kidney disease, or on certain medications, that can also slow it down. Okay? The longest half-life I've seen is 30 days. Guy with a bad liver. Okay? So the average on admission here at Serenity Lane, what do you think? Okay, average THC level is about 300. Excuse me, it's about 800. So if you're a casual weekend marijuana smoker and you're smoking some good Oregon flower, 1 gram joint, 33% THC, you smoke the joint, you're likely to have a THC level on Monday or Tuesday of about 300. So average here at Serenity Lane on admissions about 800. So we can do the math, right? So 5 days later, you're at 150. 10 days, you're at 75. 15 days, you're at 37.5, and you're under the cup and likely to pass. So what's the internet going to tell you it takes to have a clean urine? 30 days. Yep, never had an audience get that wrong either. Okay, so you do the math here, 400, 200, 100, 50, 25. So 5, 10, 15, 20, 25 days, right? So the internet will tell you just for safety, 30 days. Yep. Yeah, because it's half of what's in your system. How long does it take for half of it to get out? So it takes 5 half-lives to get to 0. Yeah, that term's called pharmacokinetics. And every drug and every chemical, we know what those half-lives are. It's extremely variable. That's why they tell you 30 days on the internet. And it's the factors that make it variable are what I just talked about. You know, body, habitus, and are you on other medications? Do you have liver and kidney problems? So, yeah. So good questions. Okay, so what's the record at Serenity Lane? 16,500. Okay. This gentleman was acutely psychotic, and he left before I could ask him how you do that. Okay? So THC receptors, there are some up here in the frontal lobe. So if you get your THC level high enough, pun intended, that you can hallucinate. Okay? That's somewhere on average around a level of 5,000. Almost every human being will start to hallucinate. So there are THC receptors all around the midbrain. What do you like on THC emotionally? Playing video games? Right? Okay, so the next record is 12,750. Nice young lady named Kim. And we thought Kim had a major psychiatric illness because she walked around for 3 weeks. Okay? So the lab got back to me 3 weeks into her stay with a little asterisk, little footnote. Said, sorry about the delay in getting this result to you, but we had to recalibrate our instruments twice to get an accurate number. So it begs the question, how'd she do that, right? So I had to go ask her, right? About week 3, she smiled for the first time, and I asked her, and she said, well, I ate a half a pound of gummy bears coming in the gate, okay? Which begs the next question. Why did you do that? And almost everybody knows the answer, because I had them, right? That's good addictive thinking. I ate them because I had them. The last hurrah, I'm coming in the gate, I'm going to use what I have. It's a very common phenomenon. Okay, so do the math. 6,000, 3,000, 1,500, 750. So you can just do the math on down. So 2 to 3 weeks in, she's still stoned to the bejesus, right? It took her that long to clear it before she would start to come out of her situation. So here's how I like to end this part of the discussion. Is marijuana addictive? Sure it is. And when are you going to see the withdrawal from marijuana? Knowing this. Yeah. So typically you're going to see it about week 2, right? And what is that going to look like as we strip the THC off of our midbrain? Okay? Are you going to be emotionally doing well? No. Are you going to be sleeping well? No. You're going to be irritable. You're going to be sensitive. You're going to not be sleeping well. You're going to be having a bad day, right? And are you going to say to yourself, I'm having a bad day because the last time I smoked pot was 2 weeks ago? Of course not, right? So when you suffer what the Big Book calls the vicissitudes of life, commonly known as stress, triggers our midbrain. Well, what is stress? Oh, my car didn't start this morning. I'm late to work. I'm going to get fired. I won't be able to make the house payment. My wife's going to leave me. And you get into that cycle of thinking, right? So if your midbrain is extra sensitive because we've now stripped off the THC and you say to yourself, I just want to relax tonight. I just want to chill out. Or I have anxiety and I'm going to use marijuana to treat my anxiety. Okay? Are you suffering marijuana withdrawal or are you suffering an anxiety problem? Okay? So I always like to leave the last part of this lecture to think about that, right? So, and what do we do about that? What do we do about that? So, is marijuana addictive? Is there a withdrawal? When does it happen? And does it leave me susceptible to the vicissitudes of life of triggering my cycle of addiction? And what does that look like? So, 60 to 80% of patients that admit to Serenity Lane have THC in their urine. So, any questions? Okay, so next week we come back and we review some of this, disease of addiction, and we talk about the treatment of addiction. What do we use medicine-wise, and what else do we do here at Serenity Lane to help with these problems? That's what I got for you today. you.